to welcome to the stage none other than Dr. Mathonsi.
Thank you so much for the warm welcome. I think we are enjoying ourselves here. My talk is on the HPV vaccine, an update. That's okay. Just from my starting, I want to say HPV, as we all know, that it possesses anogenital and oropharyngeal disease in both male and female. Persistent infection virtually causes all of the cervical cancers. The high risk HPV genotype 16 and 18 are approximately causes 70% of cervical cancers worldwide. The additional 20% come from the subtype 51, 53, 45, 52, and 58. As we know, we have the other one that causes a benign disease, which is subtype 6 and 11, that causes 90% of anogenital ones. If you look at the estimated world burden of HPV-related disease, focusing specifically on a cervical disease and genital warts, we all appreciate that HPV is a very, very common infection. Worldwide, if you talk about estimation of about 3 million people which are being infected with HPV disease, and amongst those, 10% of them will end up having a genital warts, and 10% of them again will have a low-grade disease, cervical lesions. And we're talking about 3% will end up with a high-grade lesion, a precancerous lesion, and a small percentage of them will end up with cervical cancer. And those are basically 1.5%. And if you look at the reason why, the larger population, if you look here, if we look here in this triangle, you see that the burden of the disease here is mainly due to a non-oncogenic HPV type. And the other side, the bigger triangle, with a few percentage of them end up having malignancies, it's mainly due to more of an oncogenic type of HPV. And if you look at the risk of a new infection by age group, we'll all appreciate that. If you look at this graph, majority of the new infection occur here at the teenage side. If you look at around the age of 15 and 19, that's where majority of new infection, and you can appreciate that as we get older, then the risk of a new infection goes down. It's important to look at this diagram here. As I said, it's a very common infection, and this infection goes to infect the new cells, HPV. What usually happens with the infection of HPV, you can either, when you have an infection, you can clear the disease, it can either progress into precancerous cells and eventually invasive cancer. But if you look here, the patient here, where we have a new infection here, and you look at the graph here at the bottom, we'll all appreciate that the different type of a screening program that we are talking about, they're not that very, very effective in the terms of management of this cervical cancer disease, or to reduce morbidity and mortality of the cervical cancer. You look at if you look here on the cytology, which usually is being initiated at around the age of 20, it's not that very good. it's not that effective in reducing the burden. And if you go again, because of all our challenges, it's even worse in our setting. And you look again, the core testing as well, it's not that optimal. But what is ideal? What do you think is the ideal thing? You look at here, as I say, cytology is not it's insufficient. It's not optimal. What is ideal? I think ideal is HPV. We've been talking about this burden of cervical cancer since morning. But what is ideal? How can we overcome it? The ideal thing is HPV vaccine. That's the ideal thing. Combined with the, if it's possible, with the HPV screening, primary HPV screening. Even if you have one test of a primary HPV screening at this age group, that will go far. And if you look again, this HPV, if you look at the age-specific HPV prevalence in a different continent amongst women with normal pap smear, look at the different continents. Look at Africa. Our HPV prevalence in a patient with a normal cytology is very high. It's as if we expect it to clear. Look at the other continents. Example, look at the Europe, look at North America. Yes, we can pick up, we can see there, all of them. The new infection is higher at the early stage. But we expect that disease to clear as time. But look at Africa. What's happening to Africa? What's wrong with us? Is it genetically? Is it mainly because maybe we have more a high-risk type of HPV, which causes persistent disease, a more oncological type as compared to other continents? That's the question. And you can see here that the normal smear, it does not necessarily mean that you are cleared from the disease, you are free, you might not have a disease in the long term. So we sometimes say that the normal smear, we reassure patient with the normal smear, but you can see here, but the risk of persistent HPV, which is the problem, the persistent HPV, that's the biggest problem, is the one that we see here in Africa. And then what are the measures to control, or what measure can we put to control this disease? Well, we have, as you probably mentioned before, as you can see here, we have a primary prevention, we have secondary, we have tertiary prevention. What can we modify here? Risk. Everyone is at risk. You say 80% of women will end up having HPV in their lifetime. That's what we say. So we can't change that. They're going to be exposed to HPV, as we see at the beginning, that 80% of women will have HPV in their lifetime. And then you look again, okay, if we cannot have infection, they can have can we do something about the screening? As I mentioned, we're not very good in that screening. Tertiary management, early diagnosis, treatment, we're not good. Probably our best shot of overcoming this battle of cervical cancer is primary vaccination, primary prevention with vaccine. That's our best shot. And most of the effort should be concentrated towards that, because that's the best shot. Whatever we try to do in the limited resource countries, we're going to have a lot of obstacles. There are big challenges, starting from a screening, as a tertiary, as a treatment, we all have problems. But if we can get it right here, we're going to overcome lots, or able to prevent a lot of death from cervical cancer. Okay. What is an approach to cervical cancer prevention and control? As I mentioned, we have a primary, secondary, which for sure we're not doing well in all these areas of secondary screening prevention. We're not doing well. We're only talking about our challenges here. African limited resource country, middle income, who faces challenges. Treatment, it's a challenge. Palliative care, we're even failing to give these poor women just a palliative care. So who are not doing well, but we can do better. The primary vaccination. I was glad to hear that we do have a bivalent vaccine here. So we can do better. Okay. If you look at the cervical cancer, almost all of cervical cancer, almost all, caused by HPV. Almost all. If you look at the burden of HPV, it's mainly on cervical cancer compared to other diseases. And 70% of those subtypes is 16 and 18. You see here, 100% of all are attributed from HPV. And that's what we see here, the 16 and 18, and those are the commonest one. Let us look at the other burden of this HPV on the other side. You can see here, although it causes some other genital disease, as a vulva, vagina, and all that oropharyngeal disease, but the burden is mainly on cervical cancer. And that is our biggest problem. And that's where we're losing most women. If indeed our problem with HPV is a cervical cancer, and cervical cancer is claiming a lot of our women, how can we reduce that? Vaccination. Look again, worldwide, still, what is the problem? HPV 16 and 18 contribute about what? 70% again. So this is the biggest problem, biggest culprit, these two. If you look at in other developing countries, like in South Africa, we also have 45, it's the biggest problem. It's being included in one of our high risk tests. When we check the high risk value, we include 45. And if you look, different continent, Africa again, 16 and 18. Throughout, 45, you might see it sometimes, it might not as much as it is in other continents, but it's also number 3 in terms of HPV that contribute to cervical cancer development. Okay, then let's look at the types of histological types. As we know that the common type would be squamous cell, about 70%, 20 to 25% with the adenocarcinoma. 16 and 18 again, which is the biggest problem. This is our biggest problem, biggest enemy, 16 and 18. Look at it, they are really the problem in contribution of cervical cancer compared to the other, all other one combined. So if we can manage to prevent or deal with these two, we're going to make a significant difference in terms of prevention and reducing of morbidity and death from cervical cancer. If you look again here, age-specific rates of HPV infection in the cervical cancer, we know here majority occur at new infection, early stage. That's why we're having a problem. And then as time goes on, you know that the incidence of HPV declines, just gradually goes down as the incidence of cervical cancer increases. And you can see, but this curve is not how it looks in Africa. In Africa, what I've shown that this curve continues to be at that level, to be high, which means even the risk of cervical cancer might be even go a little bit higher, which is very important for us. Okay, let's talk about the vaccine. What do we have available? We have a Gardasil, a quadrivalent vaccine. We have a 9-valent vaccine. We have a bivalent. That's what we have. With these 3 different types of vaccine. Most important about this vaccine is the composition. If you look at here, at the bivalent, the composition of bivalent vaccine, this is a viral-like particles. It does not contain any genetic material. It's just viral-like particles, antigen, just to stimulate the antibodies. And combined with their adjuvant, that's what makes the bivalent. Same applies with the quadrivalent, combined with the adjuvant. The adjuvant here, it plays a very important role in terms of immunogenicity, development of that immunity against the development of cervical cancer. I will show that later in the last stage of the presentation. Look, we said HPV peak is around the age of 50. New infections, very common there in a patient with a, more special for patients with a non-HIV patient. Okay, as it peaks, what's happening here is that maybe some few years later, you start seeing that a pre-malignant infection, those who have what? Persistent disease. Okay, then later on, that's where you see cancer. Okay, what about HIV patients? Let's look at the HIV patient. How does this guy behave? The HIV patient, have a little bit there. The risk of infection is much higher in HIV positive patients. And look at the difference between the two. And you can see here, this is the sharp decline as compared to HIV, which means the attempt to a more persistent disease, which is the problem. The persistent HPV, that is the biggest problem. If you can tell it, it's okay, but the persistent disease, that is the biggest. Then in HIV, again, look at the difference again. You tend to have early cancers. And the peak is even much higher than the non-HIV. Cervical cancer, again, you start seeing it much earlier, and it continues much higher than the non-HIV. And as we know, HIV is endemic in Africa, very common. Cannot shy away from it. It means this is our patient, majority of our patients. This does not have that much impact in Europe, in America. This really speaks to us. Okay, that's where we are. HPV vaccine. How can we make an impact? You see here, we want to come and try screening here. Late. I mean, it's okay, let's do it today, let's put up the system, protocol, guidelines. We miss the boat. See, if we can do it much earlier, here, but here, at the area before the new infection, which is very common here at around the peak there, the biggest intervention that we need as Africans is here. I heard a very good talk about screening. It's not bad. For those who have missed this, it's not bad. But if we can make sure that our girls get vaccine, I'm telling you, it's gonna pay off in some few decades to come. Gonna yield a good results. Okay. We have concentrated so much effort in screening. The talk is mainly about screening. Whatever we talk about screening. So much effort on screening. I think we need to redirect our effort to vaccination. And this vaccination, we're going to overcome most of this problem. We're talking about 20 to 80% approach. So that small problem, we're going to solve the other problem as well. So this vaccination here is going to solve most of these problems. So if we can concentrate much more on vaccination for our girls, so our problem will be solved. Okay, how is this vaccine that we're talking about being administered? You see, here they say a routine HPV vaccination is recommended between the age of 9 and 12. Before what? The sexual debut. It can be administered starting from the age of 9. Before, again, the emphasis is before. And I'll show you why before. Why it is important to vaccinate it before? Because of that adjuvant in the composition of the vaccine. That makes it very, very, to make a very significant difference, that adjuvant. For those who have missed the boat, of course, catch up between the age of 13 and 15, 26 or 15, or after the age of 15, they can get the recommended the catch-up vaccination there. It's recommended. But beyond the age of 27, it's not routinely recommended, and the benefit is probably not as much as good. Optimal timing. Optimal time of HPV immunization in a vaccination or immunization is prior to sexual debut. Patients who are HPV naive. Very important to know that none of the available HPV vaccine treats or accelerate the clearance of existing HPV infection or related disease. There have been some attempts of some study to check, can it really accelerate the clearance of the genital warts or of the pre-malignant lesion? No evidence suggests that it accelerates or help with the clearance of the disease. An individual who are sexually active can still be vaccinated, but even those who are HPV positive, but so the benefits, it's just limited benefits as compared to those who are HPV. Okay, what are the contraindications? Is it contraindicating someone with a history of HPV infection? Either they have a genital one or they have a previous abnormal smear? No, it's not contraindicated. Is HPV vaccine contraindicated in the patient who have a what? No, no. Someone who have a proven HPV infection or abnormal pap smear? The answer is no. It's not contraindicated, but the benefits are probably less. Therefore, the choice, we have 3, as I showed, vaccine that you can choose from. And the problem here, not all vaccines are available in all nations. Of course, and availability is not an issue, for sure. Go for Gardasil 9. And because it have an additional protection to other high-risk HPV, which can also cause cancer. Although they don't contribute much, but it has that additional benefits. And the same formulation can be used to complete the series. If someone was previously initiated and for some other reason they could not complete it, it's also possible to introduce the new vaccine formulation. Or maybe now it started with bivalent. After some time, there's no more bivalent, now there's a Gardasil 4. You can complete the series on that. or they don't know what was their first, the initial vaccine that was given to them. You can complete the series with another vaccine. Look at the immunization schedule. So 2 doses of HPV should be given at the 0 and between the 6 and 12. And if the second dose that is administered is less than five months after the first dose, the dose should be repeated in minimal of 12 weeks after the second dose and minimal of 5 months after the first dose. Those who are doing catch-up as well, catch-up. Now the doses have to have 3 doses. 3 doses for those with a catch-up. And between they have missed, again, they can also catch up there, we say it's the repeated area. What about that graph I've showed you, which is much higher? Those one HIV positive, which we have the most here in Africa, they must have the 3 doses, regardless of their age. Those who have missed vaccine, as I say, which is a problem, follow up. If the vaccine series was interrupted for any length of time, it can be resumed without restarting. Just complete it. What are the post-vaccination instruction? There's just small risk of the syncope, which is usually with most vaccine. Keep the patient for at least 15 minutes. That reduce the risk of syncope and other subsequent injuries. Previous vaccination assessment. You do not need HPV can be vaccinated without any special evaluation. You do not need a pregnancy test. You do not need a test, that serological test to check for HPV. It can be administered without any specific or special evaluation or test. Post-vaccination serology, there's no evidence that you must do that. No evidence that supports do that. Revaccination, again, does not demonstrate that any benefit. Just rushing quickly. For pregnant and breastfeeding women, vaccination is not recommended. Limited information about its safety, but if someone is accidentally vaccinated while they're pregnant, the adverse effects need to be less. Lactating mothers, yes, they can be vaccinated. Pre-existing vaccine, as I mentioned to you, it does not show any. It does not accelerate the clearance of the disease or the disease. If you look at this, for those who have catch-up vaccine, there's a belief of a cross protection that if you get a bivalent vaccine, 16A, it gives you other protection to other viruses. So sometimes, even if you get it if you have previous exposure, you might still have, that's why we talk about the benefit might be limited, but there is still a benefit for this patient. Healthcare workers, yes, we can be vaccinated because we're being exposed. That's what the one, gynaecological, all those one, immunogenicity. Look, immunogenicity, it's an excellent response. Seroconversion rate about 93 to 100%, 99, that, and the titer are generally high in a young than in old patients. This is the slide I was talking about. If you look at it, if someone has a natural infection, this is what will happen. That's the protection that you get. But the addition of that adjuvant composition, it gives you much higher immunity. The adjuvant improves your kinetics, your magnitude, and homogeneity of immunity against. So meaning that, what does that mean? It means that natural infection does not necessarily hamper protection against future disease. Women remain at risk of persistent HPV throughout their life, and persistent HPV is the cause of cervical cancer. Antibody response are poor after a natural, hence HPV vaccine. HPV vaccine. Vaccine will induce a better immune response than the natural infection. Efficacy, efficacy treatment of all. That's the benefit of this vaccine. It does not only address the issue about cervical cancer, but it's also address other issues and even give you other cross protection to other diseases. Who said it was anogenital disease as well as oral and give you the protection against almost a wide broad spectrum of a disease. Safety, you're guaranteed. No problem with this vaccine. Thank you.